Hello, everyone who's just joining us. If you want to let us know you're here, you can give us a hi or tell us where you're coming from in the chat section so that we know you're here. Give us a little hi or a little wave so we know who's joining us this evening. And we are just going to give this 1 second for everybody to have a chance to get on to our webinar tonight. Great, we've got some people joining us now. I'm going to just start off by making a few announcements, and then I will turn the program over. So thank you all for joining us tonight. You're joining the Lupus Foundation of America Heartland chapter and All In for this evening's webinar, Bringing Lupus Nephritis Out of the Shadows. My name is Amy Onder, and I'm the president and CEO of the Lupus Foundation of America Heartland chapter. We are headquartered in St. Louis, and we cover the states of Missouri, Kansas, Southern and Central Illinois. Before we get started, I want to remind you that the information provided in this webinar is for general informational and educational purposes only and is not a substitute for your own physician's advice. The views expressed by our presenter are not necessarily those of the Lupus Foundation of America. If you have questions during the webinar, please type them in the questions section, and at the end, when Dr. Wells has completed his presentation, we will answer your questions, as many as we possibly can in our time frame. I also wanted to just tell you about a few upcoming programs. On April 15th, we have the last in our series of webinars focused on pediatric lupus. This one will feature our board chair, Dr. Austin Dalrymple, a pediatric rheumatologist from St. Louis University School of Medicine and SSM Cardinal Glennon Children's Hospital. He will be discussing some of the non-medical options for helping adolescents with lupus live their best life. On April 20th, we invite lupus caregivers to join us for a webinar focused on helping them be effective caregivers for a loved one with lupus. If you have lupus, please share this with your loved ones. And then on May 22nd, we will be hosting a half-day lupus education conference called Lupus and You. The topics and speakers will be announced very soon, so save that date. And also don't forget that we have 2 support groups that meet on the 2nd Thursday and 4th Wednesday of each month. For more information about any of these programs, or if you have any questions, you can go to our website, lupus.org/heartland. Tonight's program is being recorded, and we will have that available on our YouTube channel at some point in the future. So you can always go back and rewatch this webinar. Again, reminder to ask your questions in the questions section, and we will get to those questions at the end of the presentation. So now I would like to turn it over to Mark Miller with Aurinia Pharmaceuticals to introduce our speaker.
Well, good evening, everyone, and thanks, Amy. I appreciate that very much. Again, my name is Mark Miller. I'm with the Regional Professional Relations team at Aurinia Pharmaceuticals, and it's my distinct pleasure to introduce to you this evening the speaker for this evening's event, Dr. Alvin Wells. Dr. Wells is currently a practicing rheumatologist at the Aurora Rheumatology and Immunotherapy Center in Franklin, Wisconsin, where he serves as the director. He is an assistant clinical professor at the Medical College of Wisconsin and a visiting foreign professor at the Karolinska Institute in Stockholm, Sweden. He also maintains his clinical affiliation with Duke University Medical Center in Durham, North Carolina, where he is an adjunct assistant professor. A member of the American Telemedicine Association and of the American College of Rheumatology, Dr. Wells has over 25 years of research experience focusing on chronic inflammatory diseases. Dr. Wells is an internationally renowned speaker and researcher, and in 2019 received the Outstanding Teaching Award from the Medical College of Wisconsin and Ascension St. Joseph Hospital. With that, ladies and gentlemen, please help me welcome Dr. Alvin Wells. Take it away, Dr. Wells.
Thank you, Mark, and thank you, Pam. It's good to be here and good to be part of this presentation. I tell you, as a rheumatologist, this is a very, very exciting time to be able to treating patients with our rheumatic diseases, whether they have rheumatoid arthritis, psoriasis, psoriatic arthritis, and now we talk about lupus. Because here's a fact. For the first time in the history of our disease, we've had multiple drugs passed for treating patients with lupus and lupus nephritis in the last couple of years. And this is what we're going to highlight tonight. We're talking about bringing lupus nephritis out of the shadows here. So like Mark said, my introduction, this is not me, but here we are. I'm a board certified rheumatologist and practice at the Rheumatology and Immunotherapy Center. I live in Northern Illinois and practice just over the border in a suburb of Wisconsin. So let's talk about lupus nephritis and what is lupus nephritis and what does that really mean? We know, for example, lupus is a serious chronic disease. Lupus comes from the Latin word that means wolf. So patients get this rash on their face that looks like a wolf or a German shepherd. Patients can lose their hair. They can get sores in their nose and mouth. And that's on the outside of the body. But indeed, being a systemic disease, it actually can affect internally. It can affect the heart, the lungs, the kidneys, and the brain. So with lupus, what happens, I make the analogy, the immune system gets turned on and the immune system starts attacking its own body. It'll start attacking the skin. It'll start attacking the hair. It'll start attacking the kidneys. And that's what we need to see what we do. So we give drugs that kind of dampen that immune system to get back to that balance so we can get back into repair our organs. We know that inflammation, that's those angry cells, is caused by lupus, and it can affect different parts of the bodies like I alluded to. And when lupus affects the kidneys, that's a condition that we call lupus nephritis. Now, the lupus nephritis community, like you said, about 50% of people living with lupus may go on to develop lupus nephritis in some part during their disease process. And then we talk about, of course, looking at what the kidneys look like. So lupus nephritis is a common complication of lupus that involves the kidneys. You get inflammation. These angry cells get in there and start attacking the tissue inside of the kidneys, so the kidneys cannot function what they normally do. As you know, this can be a serious health problem, and permanent damage can lead to kidney failure. And indeed, some patients do have to go on to having dialysis because of the impact that it has. So the kidneys don't function properly. They don't remove waste. This stuff can build up into the blood, and some of this can actually be toxic and can actually harm the body. So who gets lupus nephritis? And this shows you a picture, we say, of a typical patient that we see. Remember, patients who get lupus are usually young patients of color, African American, Hispanic, Native American as well. Other patients can get it too, but it's a younger patients of color that we worry about this, because they're the ones who have a higher risk of going on to developing lupus nephritis. Let's show you what those numbers look like. It's not as uncommon as many people think. Some of my colleagues say, yeah, I don't see it, but no, once you start, shaking the leaves on the tree, all of a sudden you start seeing these things kind of falling down. You see people with the disease. There are approximately 100,000 patients currently diagnosed living with lupus nephritis in the United States. And 1 of 3 of these who were diagnosed with lupus nephritis at the time of the lupus diagnosis. So think about that. I saw 2 new patients with lupus this week, and one of them did have lupus nephritis at the first diagnosis. And that's what we see as you think about that. In the U.S., I already alluded to this racial and ethnic groups that have a higher rate of lupus nephritis than others. Compared to whites, the prevalence is roughly 4 times higher in African Americans and Asian descent, and 2 times higher in Asian, Hispanics, and Native American people. So again, lupus nephritis is more common in women than it is men, just like lupus is in general, and it all is more affected by serious disease. So these are some facts to remember when you think about who gets the disease, okay? As we look at this and kind of move forward with the slides, let's go to the next one here. The signs and symptoms of lupus nephritis. We know, but the potential symptoms can be here. That gets usually swelling of the legs and the feet and ankles. I make the analogy the kidneys essentially function like a river, letting things flow. That's when you urinate. But guess what? If something blocks that urinary function, that fluid's got to build up somewhere. It's going to spill over into the body. It causes swelling of the ankles. It causes swelling of the calves. It can actually cause fluid to build up around the heart and the lungs. So one of the first things we look for is swelling of the legs and the ankles. As a result of that fluid buildup, patients get weight gain. So all of a sudden somebody has lupus and they say, hey, I've gained 3 to 5 pounds and I'm not changing my diet. I haven't done anything unusual that I wouldn't normally do. And again, increased urinary retention, especially at night. Patients don't go to the bathroom. They have to wake up at night and multiple times to go to the bathroom, because if they don't go to the bathroom to urinate, guess what? They urinate on themselves, because they get this bladder retention. The bladder expands, and you say you get that signal. You got to get up and go to the bathroom, and that's one of the things we see. And again, when you go to the bathroom and you urinate a lot, then you see this urine is not normal. The color is different. It's going to be more foamy, or bubbly, or frothy. That's one of the things that we see because of some of the things that's spilling out of the urine. It's difficult to identify lupus nephritis by symptoms alone, and that's just why, as your rheumatologist, say, hey, we're looking for other things. I'm looking at the urine to see if there's any protein in the urine. Like I said, there should be there is a dam, and making sure what things are kind of leaking through. I'm looking for blood. That's a sign of irritation of the kidneys. That we call that hematuria. And then I'm looking for what we call the abnormal electrolytes, the sodium, potassium, all those other levels, of calcium levels as well, in patients, to see if their kidneys are functioning like they should. Decreasing glomerular filtration rate. Imagine you got a water hose that's doing that water kind of flowing like it normally should, but all of a sudden that water, you got this faucet wide open and you're only getting a trickling amount of fluid water coming through. That's where you would see a decrease in that filtration rate. The kidneys are there, everything's open like it should be, but only a trickle is coming out. And that's one of the things we'll look at. And when that happens, guess what? We see an increase in a marker called the creatinine level in the bloodstream. As a result of this fluid and the weight gain, guess what? People's blood pressure can go up as well. And all of this inflammation can lead to scarring of the kidneys. And this is why we usually do a kidney biopsy to say, hey, how much inflammation is there? How much damage is there? And can I indeed give medication to reverse that or maybe slow that damage down? There are complications related to patients who develop lupus nephritis. We talked about the signs and symptoms, but we say now many patients get increased blood pressure. They could be on blood pressure medication. All of a sudden, guess what? That medication that used to work last year, 6 months ago, is requiring more medication to control that blood pressure. And also chronic kidney disease. If you think about this as scarring, you can see this in other diseases like diabetes and hypertension, but we also see it with lupus. And once the kidneys are scarred, they don't repair themselves. A good analogy I make is say, if you cut yourself, you get injured the skin, in a few days you get a scab on the skin. Okay, if you injure the kidneys, it leads to the scarring, and guess what? It doesn't repair itself. That scarring is there, is permanently there, and that impacts the kidney function. And as a result of that, we see cardiovascular complications, increased heart attacks and strokes, of course, and again, kidney failure, what we call end-stage renal disease, where patients indeed have to go on to dialysis. So again, in my patient, I want to catch it earlier rather than later. I don't want to wait till they end up in end-stage renal disease. Can I look at these patients earlier on, and can we actually do things to kind of prevent the disease from progression? And this is what we talk about here. Early diagnosis and treatment may help prevent this irreversible kidney damage. So how do we make the diagnosis, and what's the road to the diagnosis look like? So who commonly sees the lupus nephritis? It's the rheumatologist, it's us. We making the diagnosis for lupus. Like I said, we're looking at the skin, looking for hair loss. We're looking for that rash on the face. We're looking for sores in the nose and mouth. We also look for arthritis. They get this puffing of the hands and wrists. They can't button their shirt. They can't fasten the bra. Those are the kind of symptoms that we see. And then I'm doing all my blood work. I'm doing all my markers. And indeed, if I see some abnormalities coming back, suggesting kidney disease, I recommend working with the nephrologist. These are kidney specialists. Just like we experts in the skin, muscle, bones, and joints, the nephrologists are experts in the kidneys. So why do I need them? Because sometimes they help me do the kidney biopsy. They help me say look at their renal function, see we need to make changes in their blood pressure medicine, making change in the vitamin D and the calcium, all the different things they're taking. So that's why it's a team approach, I call it, to kind of put two heads are better than one, and we put ourselves together to getting patients treated on the overall. And if I had another slide, I would put the primary care doctor in here as well. I need them to be involved to control the diabetes, controlling your blood pressure, helping with the weight loss, etc. All those different things that go together. But it's the rheumatologist and the nephrologist usually make the diagnosis. The test I talked about earlier on, we know some of the symptoms. You talk about swelling of the legs and ankles. We talk about waking up to go to the bathroom. But then we do the urine test to look at things as well. This is important to see how well the kidneys are functioning. We do blood tests as well to look at the creatinine levels. But we also do these what we call autoantibodies to say, hey, who has some markers that might lead to a higher risk of getting kidney disease? Because if I see some of these factors early on, I'm going to follow that patient to make sure that she doesn't go on and get kidney disease in front of me. And this is why you see some doctors say, hey, I need you to come in every 3 months. I'm not going to wait 6 months or a year. I need to see you like clockwork doing these measures. Is this, guess what? Because if you're doing that and get people under control, many people do fine. So you go back years ago where people die earlier on with the kidney disease and the nephritis. Now we're seeing with these aggressive treatments that we have, we can control the disease in many cases. I still need a biopsy. I tell people that the tissue is the issue. You go in and do a biopsy of the kidney so I can look at it and see, is there a lot of inflammation? Is there some scarring? Is there some damage to the tissue that I may or may not be able to replace? So I do that early on, and I do that at any time again if we need to repeat that to see if we need to change our therapy. I can't tell you the importance of doing a routine urine test because the high risk of patients who develop a lupus, routine testing, what we call a urinalysis, is vital. Looking for markers that might be a signal that there's some irritations or inflammation going on in the kidneys itself. So urine test, blood test, and in some cases a kidney biopsy, all those things together help us make the diagnosis. Now I like this slide, what we call the Venn diagrams, all the different bubbles that are there. So either me or the nephrologist uses kidney biopsy to determine, hey, what's the type of kidney disease? There are like 6 different types of kidney disease that we see. And this information is important for me to look at the treatment plan. Type 1, they call types 1, 2, 3, all the way up to class 4. Class 1 is minimal kidney involvement, so that's one that we usually worry about. And the same thing with class 2. There's some evidence of inflammation, but it's limited to the areas of the kidneys. The ones we worry about the most are class 3, 4, and 5, because these are the ones that involvement of less than half of the systems of the body, what we call the glomeruli that involve. Class 4 is one that is called diffuse because it involves more than half. So it means a significant part of the kidneys are being involved. And then the membranous type is also one called, but what we get these immune deposits. These angry cells kind of float in the bloodstream, they bind to different markers, and these markers kind of settle into the kidney and kind of jam the kidney's function. And this is different from other forms of lupus nephritis. And when it gets to this advanced stage, this class 6, we call it, this is when there's scarring, we call it advanced sclerosis. Sclerosis means scarring. More than 90% of the kidneys are damaged, and unfortunately, we don't have anything to treat that part. So how do we indeed manage lupus nephritis? Like this case, to show you another example, again, treatment is vital. You talk about this as well, working with the healthcare providers, the rheumatologist to control the disease, the nephrologist to control the kidney function, and the primary care doctor doing all the other things we talked about. I'm one of the big ones that believe in educating my patients, okay? I don't talk down to my patient. I want to do it on the same level as them. They understand the disease, understand the process, understand what it involves. They got to be on the team to involve with that. If I have young patients, indeed we have patients 18, 19 years old, we might have their parents involved, get them involved as well. Or if I have a lady who just got married, it's going to be her spouse or a partner who comes in as well. It is a team approach. In addition to our drugs, we talk about, hey, there's other things you can do on your own. Talk about diet. Just by decreasing your weight, that improves your blood pressure, and then blood pressure decrease actually impacts the kidneys. Exercise. Exercise, you know, has a big impact on anything, again, cardiovascular wise, but also on the kidney function as well. And the overall healthy living. That means stopping the smoking, you know, doing exercising, watching all the amount of sugar that you're taking, etc. So all these things taken together, it's a kind of a comprehensive approach to treating patients who have kidney disease. So the potential members of the lupus nephritis healthcare team that we talked about, how you can live with the disease, these are just some of the specialties that we deal with, okay? The rheumatologist, the nephrologist, the primary care physician, and some patients we do get involved the psychologist. Think about this, you got a 22-year-old lady just graduated from college, she's got this chronic disease. I mean, that can be an impact on anybody. So we have the psychologists that work with them as well. One of the nice things that's happened because of the pandemic, you don't need to go into the office to see a psychologist. You can connect with them by way of the telephone or by way of the video. And that's covered by most insurance. That's something we do as well. And indeed, we get the dietitian and nutrition involved to help about weight loss, to help control the diabetes, to minimize the salt intake. All those things are involved. And over here, we have other specialties that if I need to, hey, I need a skin biopsy, let's get them to the dermatologist. If I had the radiologist involved, they give me some special scans to look at the kidneys or the lungs or other areas as well. And of course, as you know, the pharmacists and physical therapists. It is a team approach, a chronic disease. We're going aggressive management. At the middle of that is going to be the rheumatologist, which I think kind of spearheads everything to kind of direct the other specialists here. Working with your healthcare team, that's why I say I tell people to write things down. When you come into the office, I mean, people forget what they think of or they want to talk about, or they leave my office and call them back because they have another question. So write those things down. Talk with your family, your friends, your partner, your spouse. If they have questions, hey, what is this crazy drug? What is a disease? What does all this stuff mean? Why? Write those things down so you can talk about that. You've got to be an advocate for yourself. Right? That's the biggest thing. Keep a track of your medical appointments and your hospital visits. Every time you walk out of a doctor's office, you say, now, this is the name of the pill. This is how you pronounce it. And this is what it's for. This drug is for your blood pressure medication. This drug is for your lupus nephritis. This drug is for the inflammation, all those different things. With my clinic, we do what's called an after visit summary. So everything's kind of spelled out. This is what we're going to do. This is what you can expect from me. And this is what I'm asking of you to do. So write down your symptoms over time. Because the day I say you're looking fine, well, yeah, Dr. Wells, you should have seen me 2 weeks ago, right? So that's what we talk about. So because things can change as people come into the clinic. And organize your results from the blood work. Not everybody needs to have some fancy spreadsheet on a computer. You can have a notebook. You can have a tablet, one of those journals I like to have. That way the journals, because the pages don't fall out. Those things you can write down, write the dates and everything. This is what Dr. Wells talked about. And I can even show that I can I put drawings on some of these things for patients. All of these things we do. And don't be embarrassed to bring your medications in. You know, some people say, yeah, I eat my breakfast. My breakfast is all these pills I'm taking, right? So again, the good news, you're on a lot of medication, but we can do stuff that we couldn't do years ago. And these medications are important. And we talk about some of these are not going to be prescription drugs. Some of these might be vitamins. Like we talk about a big fan of vitamin D to protect the muscles and the bones and other things to do protect side effects from other medications. And like I stress in law, if it's not the individual patient, it's going to be a friend or family members as well. Remember that anybody you bring into the exam room with you, they have to have permission so I can discuss things in front of them. So I don't want to have your third cousin in the room with you and they're not permitted to discuss, ask questions, because indeed that patient calls in, okay, what was Mrs. Smith's blood work? I can't give that information without your permission. And ask any questions that you have. And then indeed, that's what you talk about as you go into your doctors. How do you work with your health team remotely? And this is some of the exciting thing that I've been doing over, not just last year, but for the last 7 years, doing what we call telemedicine. And indeed, now you can say, hey, if I have a question for my doctor, I can email them or message them through their electronic records. Many of them have these applications on the telephone now that you use, or smartphone, or you can do a telephone call. Those are reimbursed by your insurance companies as well, and have the questions ready for your doctors. And indeed, sometimes some patients say, hey, I have those questions beforehand, so my medical assistant can load those up. You might even print those out so I can have those in front of me. So that's some things you can do as well. If you're not good at doing that, hey, get your family, friends, get your grandkids, whoever it is, to get involved. Ensure you have a reliable internet connection. This is a challenging thing here today. You heard the president, one of the things he's talking about in the new package he's proposing is making sure broadband internet access is readily available for everybody. So you might not have it in your home, but here's one thing we've done. So last year we did a program in August at the local library in Franklin, where my office is there. So indeed, you can go to the library to get internet access. They can put you into a little room. Now you need to know the site to log in. You need to know your password, all those different things, but they can put you in the room. It's quiet, it's secure. You can go in and log in and connect with your doctor that way. Once you finish up with the visit, somebody comes in, they clean that room down, spray it with Lysol, and do everything you need to do and get it ready for the next patient. So look out for your local libraries as to where you can have internet connection if you don't have a reliable one at home. You can use a chat feature like we talked about. Hey, Dr. Wells, I saw this medication can affect my eyes. What do I need to do? Yeah, Mrs. Smith, I need you to get an eye exam once a year. You can have side effects, but those are rare. So again, a communication with your doctors back and forth with that as well. Now, I tell people one thing, I don't want to like a 3-page note, okay, because I don't have time to read all of that, but 1 or 2 key questions, 1 or 2 or 3 key concerns, and I can respond to those in real time. Wear the right clothes in case you need to show you any physical symptoms. Yeah, everybody loves these skinny jeans and these tight leggings that they put on, but I can't look at the knee joints. I can't get to those. You know, we can put you into a gown and do all those different things, but if you have stuff you need to show, make sure you have that appropriate clothing in the office as you come in. And if you can, check your vitals ahead of time. Yeah, I have my blood pressure, my weight. I have all those stuff you can do. All that you can do before you connect with us via televisit. So the telehealth is important. It could be by way of the video, like we are tonight. It could be by way of telephone. If you don't have access to a video or internet, you can use a local library. So those are things we've been able to do. So what are some commonly used treatments to treat lupus nephritis? Remember, lupus is an autoimmune disease. The immune system is turning like this. So we got to give stuff to kind of dampen down the immune system. And this is what we call immunosuppressive drugs. They are used to treat aggressive or more severe lupus nephritis because, again, if I don't do something, there's a chance that that patient could go on and get some end-stage renal disease and end up on dialysis. Steroids are ones we know. Patients know they love them or they hate them. Steroids like prednisone. Side effects that they do are common, you know, like weight gain and diabetes and stuff like that, especially if you use too high of a dose for too long a period of time. And now we're learning that you don't want to use the steroids long period of time. So indeed, if I have a patient with lupus and lupus nephritis, I'm seeing them every 3 months, and they require more than 7.5 milligrams of prednisone, I'm not doing something right. That's what the new treatment guidelines are. You want to get them to less than 7.5 milligrams. So if you have patients that are taking more than that, say, hey, yeah, well, Dr. Wells suggested maybe I need to think about talking about, are there other treatments that are appropriate for me to decrease that? Because more than 7.5 milligrams of prednisone, it has more side effects that sort of benefits are less than the side effects that we see. The blood pressure medication, like we said, some medications we can put you on to control your blood pressure, and they also protect kidneys from getting damaged. And of course, the antimalarial drugs that we talk about as well, these are ones we use. It controls not only the overall kidney disease, but also helps with their inflammation of the joints, the skin, and the ulcers as well. So a comprehensive approach with the healthcare providers, but also a comprehensive approach when we talk about treating them in different parts of the immune system. So some patients say, well, why am I on so many medications? We start out very aggressively on multiple medications, and as people start getting better, we start decreasing the medications or maybe increase the interval, how long you have to take some of these. So these are the tricks that we use, and it varies from patient to patient. What else can you do beyond medications? I always tell people eating right. This is one of the things we talk about. Of all the stuff we do, the two things that are bad for us in the American diet is the salt and the sugar. So you want to choose appropriate diet with less salt and less sodium that we talk about as well. So using like the light salt that you talk about, and avoiding processed foods. Remember years ago, our grandparents couldn't go and get all this and getting all these meats and processed things. They had the fresh fruits and vegetables, the fresh meat and fresh sausage, all the stuff they were making. And that's what we need to get back to as well. Eat the smaller portions of food, but eat multiple portions. So yeah, you should definitely be eating 3 meals a day, and maybe in a small snack in between. So one of the snacks I like to use, this looks like an avocado almost, but avocado has a good healthy fat. Piece of cheese, low salt nuts. All those things are healthy for you. Raisins, all these things you need to be able to do. And as we talk about fruits and vegetables, because again, everybody said, well, I'm just taking vitamins. But again, you couldn't go to the store years ago just get vitamins. You ate the fresh fruits and vegetables. But before you make any changes, to have your doctor, let me have a nutritionist, and they can write down a whole list of things for you to interact with and what things you need to be on for your disease. And like I said, consider adding exercise to your routine. Not everybody's going to get out and jog. Not everybody's going to get out and do this elliptical trainer or treadmill. It's going to be some other things like doing yoga and meditating. It's going to be some stretching, some deep breathing and things like that. It can be walking around the house. It can be walking around the neighborhood. All those different things we see. Some of the best exercise we like to want is what we call low impact. So you don't want to have pounding on the joints that can affect the hips, the knees, and the ankles. So walking, biking, swimming, yoga, all those different things are good. And also the elliptical trainer. Some people say, yeah, can I use a treadmill? Yeah, use a treadmill, but I say use a walking, like a fast walk on the treadmill, as opposed to trying to run, which can injure the joints. At the end of the day, you are your best advocate. I tell people I'm not some dictator, some God telling you, hey, this is what you're going to do. You're going to do my way, the highway. No, I say, Mrs. Smith, these are my options. This is what I would do if you're somebody in my family, and these are the things you can expect from me. But here's what I need you to do as well. You're going to be a good advocate, knowing your medications, knowing your healthcare providers, and having these questions to be able to ask them. I like one of the TV commercials I see. They show, I think it's a man going to get his cell phone. He asked, okay, this can I do for texting? Can I do this phone calls? Can I do my thing? Got to do all the stuff for this. And then they fast forward to them going to the doctor. And the doctor said, do you have any questions? He says, no. And the commercial is silent. It's very kind of striking, right? So we ask questions all the time about plumbers or the veterinarians, or even going to get a new telephone. But we don't ask the same type of questions for our doctors. And you need to be the best advocate when you talk about this. Be engaged, stay informed, like we say, every step of the way. I'm not expecting anybody to be a doctor, but I won't expect my patients to know about the disease, know what things they should be avoiding, know what things they should be doing, understanding the risk. Like we talked about, 50% of people living with lupus may at some point go on to get kidney disease. Know what to look for. And I write it down for my patient. You're getting a rash, fever, cough, diarrhea, but also you get swelling of the ankles, shortness of breath, or your blood pressure is going up. Discuss your options. Hey, Dr. Wells, you mentioned this drug. I said there's some new treatments out there. What do I have to do before I go on to this? Are there other things I can do? Can I lose weight before I have to go on to a blood pressure or cholesterol medication? Because indeed, one size does not fit all. You want to talk with your care team about the things you need to do and continue to learn. Just like I do, I go to meetings, I travel, and like Mark alluded to, I speak all over around the world, but I learn from these doctors and they learn from me as well. I tell people, and indeed, if you have a doctor who's doing the same thing over and over, they got you on high doses of prednisone, they're not knowing these new treatment options out there, it's time to get a second opinion. To talk with it, hey, I heard this, I saw this, what do you think about these kind of things as well? And that's why I love the lupus societies and what they've done, because they educate the patients and educate them about new treatment options and things like that. Some doctors hate that. Oh, you saw those online. I don't believe in Wikipedia or Dr. Google. No, I use that to educate my patient. I'm not going to chastise somebody for coming in. So yeah, let's talk about that. Oh, Dr. Wells, I heard about CBD. I heard about vitamin D. Yeah, well, let's discuss that. So all those different things. If you can't go to your doctor to talk about things that impact your disease, who else can you go to? If they're chastising you and say, no, don't go there, you need to think about having another healthcare provider. Because think about it, tell people, you're paying them, they're not paying you. And that's the thing to talk about. So I'm saying somebody's paying me for my best advice, that's what they're going to get. I'm not going to chastise them and say, no, you read that in the Sunday paper, you heard this on the news, I don't believe in that. I said, well, let's educate you and let's talk about this. Oh, you mentioned something I didn't know about. Let me look that up and I'll get back with you. That's the approach I have. And it's different from doctors to doctors. So make sure you have that communication with them as well. So the 50% risk that we talked about, knowing what to look for when we talk about your urine and stuff, having these discussions with your doctors, writing things down, chatting them through the messaging system, connecting with them by way of telemedicine, and continue to learn both yourself and as a your provider as well. So we talk about joining this all-in community. It really is all in. Full head stream approach, diving off the diving board to get the disease under control. There are different resources that are out there we can look at to say, hey, what we can do for patients with lupus nephritis. All, of course, things on Facebook and other places like this as well. Even now, things like TikTok, they become a source where people can get putting medical videos and things out there as well. And again, those things, hey, I saw this on the news, I saw this online. Is this something that I can believe in and talk about this as well? And then sign up for the Lupus Nephritis Awareness Kit. This is something you can bring straightforward right for the door. It helps about all the different things, stuff that your doctors will be talking to you about as well. As you heard at the beginning, Mark said, I was speaking on behalf of Aurinia, talking about the product. I ain't getting paid to do this presentation tonight, but the whole goal here is to educate you, to raise your awareness about lupus and lupus nephritis, and actually offer support and know that you have resources out there. Because at the end of the day, when we strengthen the community, strengthening you, it's going to help to treat your disease. I think that is my last slide. All right, so I went through it pretty quickly because what I want to do is leave some time for questioning. Let me open this back up, and we're going to pull up the chat things as well. And you want to remind them how to ask questions again? I don't know if we're doing it live or through the chat.
Yeah, I know Mark had some advanced questions. So do you want to start with those, Mark? And then everyone who's on the call now, if you have that, you gave some really great information. So if you still have some questions, please just go to the question or the chat section, wherever you'd like, and ask your question, and then we can get to those. But Mark, do you want to go ahead with the advanced questions?
Sure, yeah, there's a handful of questions here, Dr. Wells. So let's see. First question is, why did some rheumatologists not recognize lupus nephritis as lupus until the late 90s or early 21st century?
Yeah, and that's one of the biggest things we saw, because we're almost treating the patients separately. If they had skin, muscle, bones, and joint disease, that was me as a rheumatologist. And then we were like the primary care doctor or the nephrologist begin to see them when they saw the kidney disease. We thought that was kidney disease, maybe from the blood pressure or from the diabetes. And it wasn't until we started diving into the immune system, doing kidney biopsies, where we begin to see that, hey, lo and behold, there is inflammation. And the same inflammatory process that can affect the rest of the body was indeed infecting the kidneys.
Okay, perfect. Thank you. Let's see. Here's another one. I've read that many people with lupus develop other autoimmune diseases. Is there one that happens more frequently than others? And if so, what might that be?
Yeah, that's a tough part. So remember, this is autoimmune disease like lupus, where the body's attacking against itself. And we know that these diseases love to run in families. So some patients will have lupus that can get another condition called Sjogren's syndrome, when they have dryness of the eyes and mouth. Some patients with lupus can go on to get some eye disease. Like I said, they can get alopecia, where they lose their hair. And all those things we targeted for different areas. So there's certain different diseases that we can see even in patients who have a background of lupus. And this is why it's a stress again. There's a chronic disease. You can develop other disease on top of that, but you can also get complications for medications, which is why I need to see you like clockwork every 3 or 4 months to making sure that we prevent any side effects and we catch the disease sooner rather than later.
Great. Let's see, next one. What are the warning signs for developing lupus nephritis? This particular question, somebody unfortunately has systemic lupus, and their doctor's indicating that their kidneys may be struggling. Is it likely that an SLE patient will develop lupus nephritis?
Yeah, like we said, about 50% of patients with lupus will go on to get lupus nephritis at some point in the disease. And that's why we look for the warning signs. So the doctor should be doing the kidney test, your urine, every time you come in for the blood work, because that's how we pick things up. And then the symptoms that we looked out for: swelling of the legs and ankles, shortness of breath, weight gain that's unexplained, and an elevated blood pressure that's not was controlled before. So all those are features that we look for, but the onus is on me. It's up to me to say, hey, based on your blood work and your urine test, I'm seeing a little hint of something going on. I'm not going to keep waiting until the cat's out of the bag. I'm going to say, hey, let's get you early on, maybe doing a biopsy, getting this stuff done, and then based on that, we decide if you need to be on a treatment for the lupus nephritis.
Great answer. Let's see, here's another. I've taken both Plaquenil and methotrexate since being diagnosed with lupus. I've been able to cut the dosages in half and feel that I'm able to function well, and inflammation markers are good. By doing this, what do I gain?
Yeah, so like I said, many patients, we start off very aggressive with their treatment, and as they start getting better, guess what? We start decreasing the treatment. We kind of spread those things out because we know, what's the old song like we used to say, love is like oxygen, you get too much, you get too high, not enough, you truly die. The same thing with our medication. We know these medicines are good, they work for the disease, but all medicines have side effects. You hear these TV commercials, some people say, oh my gosh, the side effects sound worse than my disease. They don't want to take these drugs, right? But that's where we come in. We play around with these drugs. We decrease the dose. We spread them out. Like the nice thing about some of these drugs, you take them once a week, like methotrexate. So as we hit it under control, as people start getting better, guess what? My job as your rheumatologist is going to see what's the least amount we need to control the disease. Guess what? If you flare, we go back on those medications. So it go up and down over the course of the disease history. We see those patients. Everybody say, well, why is my doctor doing that? Each patient is going to be different. The types of drug, the type of disease that we use. So no individual patient reads the textbook.
Okay, this is a broader question, Dr. Willis, but a really good one. How does your lupus respond after a transplant? And what are some of the things you need to monitor after transplant?
Yeah, so unfortunately, there are some people that go on to get a transplant. We're struggling because, again, the number of patients who go on to get a transplant overall, they're less in people of color, mainly because people are not donating the blood and doing things to see if they are on the donor list for that. And as you know, I wouldn't be able to match it with you, Mark, or something like that. I need to have somebody who looks like me, has the genetic makeup as me to match to get this kidneys. The good news, if you do get to the point where you have a transplant, you don't have to have dialysis anymore. And to keep the body from rejecting the transplant, we put you on these immunosuppressive medications. So as we're treating the kidney transplant, we're also treating the disease. But the nice thing about the transplant is the kidney function is there. I'm not worried about dialysis and all these other things that we go on. Here's the good news, that we're seeing less and less people that are going on to having kidney transplant because we have effective therapies now.
Okay, that is all the questions that I have.
Okay, let's leave what's in the chat box.
We do have a question that was just asked. What is the most recent medication for lupus nephritis and how is it administered?
Yeah, so again, not to go into detail about a whole lot of medication, but again, we have several different ones that are out there. The newer drug that we talk about is Lupus, is a pill that you take twice a day. We have another drug, Benlysta, which is an IV, a sub-Q drug that you use. Each of these have different mechanisms. Each of them have different side effect profiles, and that's why you're talking with your doctor, your rheumatologist, your nephrologist, to see what's going to be appropriate with you as well. Mark mentioned some other drugs, and all these drugs almost fall into the family of chemotherapy. And I need to be careful with these drugs, particularly a young lady who might want to get pregnant, particularly a young man who wants to father a kid. All those things have to be taken into account before I'm pulling the trigger on some of my medications. The good news, we have treatment options now that we didn't even have a year ago. I mean, this is amazing with 2 new drugs that we have out now that I didn't have this time last year.
That's really very exciting for lupus patients. I mean, we've come a long way. I don't see any more questions. Do any of you have questions? Now's the perfect time. I always tell people you have a rheumatologist at your beck and call right here, and is willing to answer any questions. So I will give you all just 1 more minute here if you want to type your question in the question section or the chat section. I know a lot was covered tonight, so he may have answered a lot of your questions. I did have a question. So is the new Lupus drug, is that indicated for children, or is that only, do you know?
So no, the Lupus is only for adult patients over the age of 18. And while we're waiting for more patients to come in, I can't stress enough, one of my biggest pet peeves, I have patients who come into me for a second or third opinion, and they've left one doctor because they didn't feel the doctor was listening to them. They didn't feel the doctor was talking. They didn't feel like the doctor, and this almost makes you cry, because I tell people at the end of the day, this young lady with lupus could be my daughter. This lady could be my wife or my mother, and they're going to get the same kind of treatment. Nobody needs to be going to a clinic where they got to wait 2 hours to be seen, because I would not treat my mom that way. Nobody needs to be on drugs and, hey, you're doing fine, and they're not doing the test that we talked about as well. You should feel comfortable asking these questions, and they say, hey, my doctor won't even talk to me, don't touch me to do an exam. I mean, all those different things. I mean, I'm blown away when I hear this stuff that happens in 2021 about what doctors and other people are doing, and that I would not treat my own dog this way, and that's the kind of thing. And I really get upset about that as well. This is a chronic disease. It requires aggressive treatment and aggressive monitoring. I see my patients like clockwork every 3 or 4 months, and in between that time, that's when they can message me, they can write down questions, they can submit all these different things. Sure, it takes a lot of work, it's time, but guess what? That's what you're paying me for. And I push my colleagues to do that as I go around and do these lectures and everything, do as well. I said, if you got some of these drugs that you're using from the 50s and patients still have active disease, you need to be a little bit more aggressive. And that's why, as doctors should learn, show to the patients as well. So feeling comfortable. I know the patient, oh, they even get embarrassed. Oh, I'm coming in for a second opinion. I don't want my doctor to know. No, you want a second opinion, because guess what? I might, hey, write down these things to talk back to your doctor and have them to do that plan at your own home. So those are some of my pearls that we talk about as well. I'm killing time just to see if there's anything else in the chat box here.
We do have a couple more. What is neutropenia's association with lupus?
Yeah, so one of the things that with the immune system with lupus, it affects the blood cell count. We have the white cells and the red cells. The red cells, as you know, to cause anemia and stuff like that. Of the white cells, there are several different types, and one of them are the neutrophils. Neutrophils can affect they're the cells that need to go in to fight infections like bacteria. You get a strep throat infection, or you cut your hand. There's the cells that go in and kind of remove the bacteria. There are some patients with lupus, those numbers go down because the immune system are targeting that part of the immune system. And on these medications, that number should go up into that normal range, because the lower that neutrophil count goes down, the higher the risk of infection is.
Benlysta is not as effective for African American women. What would you say to a woman who's concerned with this medication as a treatment?
So, and again, that's one of my pet peeves, and I tell my doctors and colleagues about that as well. So I'm an immunologist, and I know the immune system, and the way the drug like Benlysta works, it works on part of the immune system. And guess what? We're not like different strains of rats or mice that we do in the lab. We're all humans. Our immune system is the same. If I took this drug itself, it's going to have the same impact it would have on a patient who is not African American. That's a fact. The challenging part in the clinical trials is that the lupus doesn't like one patient with lupus might have hair loss, the other patient might have kidney disease, but they all will consider lupus. And as you see in the clinical trials, they only had a small number of African Americans in the clinical trials. I can tell you that the majority of my patients who are on that drug, they are African American, and the drug works. So any doctor tell you it doesn't work in African American or Black patients, they're wrong. It's just because that's what was said in the package insert for the different drug. And this is why we need to look at this stuff and because the drug definitely does work. Again, not one drug doesn't work in all patients. Your doctor's gonna make that decision, but they need to know what the impact that it has on the immune system and what these things do. And I think people say doctors are not willing to use these drugs. We got people on some older drugs. If they don't want to use Benlysta, guess what? We got Lupus with other treatment options as well.
Someone is asking what would qualify you for Lupus? What would be the qualification to be able to get it?
Yeah, so bottom line, you have lupus, you have lupus nephritis. I talked about the 3 different classes. We'll talk about class 3, class 4, class 5. We usually have a kidney biopsy, or they have abnormalities of the blood counts of the urine. We can see all these different changes, the things that I'm looking for and the nephrologist is looking for as well. Because before we had a drug like that, we were going to talk about steroids and other types of real aggressive chemotherapy. Now we use those background drugs, but we use the lupus on top of that, and actually decrease the amount of medicine I need, other medication, to get it under control. So your doctor will sit down and talk with you. There are definitely some things we need to know. There's some things where we can't do it based on where the kidney function is. So we definitely have a lot of different guidelines to say who's the patient who needs a drug and who's the patient who would say they're going to get the best response.
Is it true that African Americans have low white blood cell counts? I've been told this by doctors.
So no, turns out that many African American patients have a higher white cell count just in normal levels. But what we do see that white cell count that can actually go down, then we worry about in somebody with the right genetic makeup, with the family history, etc. Could that be the beginning signs of lupus? And that's why we need to kind of monitor those things. So some doctors tell you, white counts, no, we're all humans. We have normal ranges of all those different things. If your numbers are on the low side, I might kind of follow that every 3, 4, 6 months to make sure that number doesn't go lower. Because if it goes lower, I might do the trigger to say, hey, let's do the test for lupus, looking not only at the blood, but looking at the urine to make sure there's nothing going on.
Someone is wanting to understand why more women have lupus than men.
Yeah, you know, that would be the Nobel Prize if I understood that. The part of the right thing is that with our diseases, with the rheumatologists, as I said, we treat diseases of the skin, muscle, bones, and joints, and most of our patients are female patients. At the end of the day, we think it's more driven by estrogen and the female makeup and hormones and things like that. Because some of our diseases, ladies, when they go into menopause, they don't get these diseases anymore. There are other diseases that can occur with those, but we think it's due to the effect that the female hormones can have on the immune system, can have on cells that make these angry, what we call cytokines in the bloodstream. But it's just one of the things we can see. So whether it's rheumatoid arthritis, lupus, and other diseases, we can see these more common in women than in men. Now, men don't get off scotch-free because we have other diseases they get. They get gout, they get ankylosing spondylitis, they get psoriasis, they get all these other things as well.
There's some questions around diet, and I know we get asked this a lot. Is there such thing as an autoimmune diet, or is there a diet that people with lupus should follow?
No, and I hate that. There's a lot of stuff out there online. People look at these books and all this kind of stuff like this. At the end of the day, guys, we tell people everybody needs to eat 3 meals a day. They need to eat 2 or 3 servings of fish a week, 3 or 4 servings of fruits and vegetables a day. You know what I had for breakfast this morning? A boiled egg, 2 pieces of turkey sausage, blueberries and strawberries, and a half of avocado. That was my breakfast. Okay. At 10 o'clock, I have a snack. I usually have some more nuts with some blueberries. I have my lunch and another snack in the afternoon. Like I said, there's no autoimmune diet. It's going back to what our grandparents used to do. Ate the fresh fruits and vegetables, the fresh meat, the fresh eggs, the fresh cheese. All those things are what we need to get back to doing. The challenging part, I know in some communities, I can't go down the street to Whole Foods or wherever, Sam's Club or Costco. You don't have all these different things they call food deserts that are out there. But it's just a whole natural fruits and vegetables that we talk about. I'm not a big fan of a lot of vitamins because indeed, if you take too much vitamins, the body's smart. It's going to store it somewhere. You're going to pee it out. So many people spend a lot of money on vitamins and you just urinate it out. That's why your urine looks all yellow and dark because that stuff is just all coming right back out. So a limit, like for me, I only eat a hamburger at least once a month. I don't eat more than that. Beef, I limit the amount of beef that we're eating. But it's going to be the lean meats, pork, chicken, and fish. But I'm really a big fan of eating fish several times a week. But it's the fresh fruits and vegetables that we need to do. And then limit the amount of white stuff in your diet. The white means the sugar, the bread, the pasta, the white potatoes, the rice, all those different things. For example, I'm teaching people as well, instead of eating a white potato, you can eat a sweet potato. Instead of mashed potato, you can eat mashed cauliflower. I don't eat carbs. My wife made once these mashed cauliflowers. I've eaten this thing. I said, wait, you sure this is not mashed potatoes you sneaking in on me? I almost got mad at her, but it's mashed cauliflower. It tastes the same as mashed potato. Absolutely amazing. So all those little tricks and trades things you can do, but fresh fruits and vegetables, multiple cases of fruit, fish and things like that. You're getting all the natural vitamins. You're getting all the nutrients that you need. And guess what? You're doing that, it's going to decrease your cholesterol, your blood pressure, all those different things. So don't be fooled by all these fad things that are out there on the diet and stuff like that. You hear on the radio on the Sunday afternoon. It's going to be fresh fruits and vegetables, fish and things like that, and limit the amount of red food, but also all the white stuff, sugar. And here's one little big pearl we've learned, guys. It is just the diet drinks. The diet drinks, it turns out that obesity went up when diet drinks came around, when caffeine and all that stuff was discovered. Because again, your body sees a chemical like caffeine and all these artificial sweeteners, it's either going to pee it out or it's going to store it somewhere. And when it stores things like these artificial sweeteners, guess what? The body stores that for energy later on. And it turns out the diet drink makes your weight go up. So it turns out it's not so much the sugar, it's the calories and other things that and the amount of carbohydrates that are in that as well. So you go to 7-Eleven and get that big gulp, if I'm drinking a diet, you go to the movies and get this big cup of soda, Diet Coke, it's bad. You really should be drinking fresh water, other fresh juices and things like that.
Still some diet questions. So you had mentioned vitamin D. Is there any other vitamins that you suggest people take?
So no, right now it's vitamin D. We tell people not to take any extra calcium. The calcium to come through your diet. So eating cheese, milk, and yogurt. Many African Americans can't do that because of lactose intolerance, but they can eat, things like kale and spinach and Brussels sprouts. All those things. There's going to be natural products that we need to do. But people taking all these other things. So again, I'll give it to you, like anti-inflammatory things like turmeric and garlic, cinnamon, curcumin. But again, guess what? All that can be done into your diet. You can add those spices to your meals. I don't need to have some pill that's got all these products to hold it together, got food coloring in it, got all this artificial stuff in there. No, sprinkle some regular turmeric, a cinnamon in my coffee. garlic in your food, all those different things, the natural stuff. Other than vitamin D, for the most part, we don't need anything. Now, as I follow lupus patients, I'm going to look at the electrolytes. Hey, if your calcium is low, I'm going to give you to have to take some extra calcium. Is your potassium low? I'm going to give you some extra potassium. So we're monitoring things to see what you really need. But with a normal, healthy diet, you don't really need a whole lot. Now, if somebody's a strict vegetarian where they don't even eat chicken or fish or any meat at all, they might need to be on some other vitamins to replace what they're not taking into the diet. But with a standard American diet, particularly with the low carb and low of the white products, you should be getting everything you need.
I guarantee you, everybody, if you follow that diet, you are going to feel better. You won't need some anti-inflammatory diet that somebody made up. So I really do encourage you to take his words to heart.
That's really true.
Yeah. We have one last question here. Someone is saying that they are iron deficient. So what would you suggest there? She's saying, why limit red meat? I mean, it's kind of clear why to limit red meat, but there are other ways I think you can get iron in your diet.
Oh, absolutely. There are other ways you can get iron, but some people that do have lupus, they can have anemia, and sometimes anemia is due to iron, and that might be one vitamin that we have to take so to get those iron levels up, because it can affect the red cell count as well. In severe cases, we have to give iron IV to get them through the IV to get that levels back up as well. So again, use that to talk with your the doctor about that. Here's my other little pet peeve about vitamins. You go to the vitamin, first of all, I can't write a prescription, and these vitamins are not cheap. I mean, they could be $30 or $40 for a bottle of vitamin. I got people coming in on 4 or 5 different vitamins. They own all these different supplements, and they're upset about copays and things like that. But yeah, some people have iron deficiency. That's a medical diagnosis, and sometimes you need a prescription for iron to get those tablets up. But guess what? Once your level's in that normal range, I'm gonna go down to the iron tablets like 3 times a week, maybe once a week, and talk about this as well. Then doing other things to your diet. So the red meats that we talk about as well. But again, we really want to limit how much red meat, because there's all the stories about, stomach cancer and some of these other things about meat and how you cook it and things like that. So talking with your doctor, if it is iron deficiency, they're going to treat that appropriately and kind of go from there.
Okay. I think that's all we have time for. So I would just, on behalf of the Lupus Foundation, like to thank Dr. Wells. This was an excellent presentation. You were a great presenter. I think a lot of people are going to be envious that you are not in our area, but we're so appreciative that you joined us tonight. And I just want to remind everybody that we'll be sending out a brief evaluation after this is over. And if you wouldn't mind filling it out, it helps us make sure that we are providing the kinds of programs that you would all like to see in the future. Mark, anything else you want to say?
No, that's no. I appreciate everybody attending this evening, and thanks very much for your hospitality, Becca. I appreciate it, and thank you, Dr. Wells.
Thank you all. Thank you. Okay, thank you.
All right, thank you. Bye-bye.
Bye.